Good morning, good afternoon, good evening, everybody calling in for this webinar. The webinar is organized by UPPMD and all its members. As you know, the group is getting larger and larger, and we are all very grateful that Prosensa agreed to have a webinar with us and tell us more about the updates of their ongoing program. The first speaker will be Giles Champion, and I'll give him the word.
Thank you, Elizabeth. I'm Giles Campion. I'm the Chief Medical Officer and Head of R&D for Prosensa. And I should like to thank UPPMD for giving us this opportunity to update everybody about what we're doing at such a busy and exciting time for us. Since Prosensa is a public company, I just have to show this forward-looking statement before going on to talk about what we hope to cover during the course of this call. We will just bring you up to date with where we are in terms of recent events. I'm sure you're all interested to hear more about the redosing program, which we just announced recently having started. We'll give you an update on the regulatory process that we're following at the moment. Talk about the confirmatory clinical trial that we will be starting shortly, and give you an update on other Prosensa Duchenne programs before going into a Q&A session. What I'd like to do next, though, is it gives me great pleasure to introduce a new member of the Prosensa family, Tony Hall. He has joined us as Head of Medical Affairs, which means he'll be devoting a lot of his activity to coordinating together with the rest of the clinical team, all the programs that we're starting now in preparation for making Drisapersen available to as many people as possible, assuming regulatory approval. So Tony has a long and distinguished career in developing medicine, has a lot of expertise which we'll be making good use of, with specific expertise in rare diseases, both in terms of charity work, but also in terms of working with organizations trying to find a better way forward for the development of drugs for rare disease. So Tony, can I hand the microphone over to you?
Thanks, Giles, and hello to everybody. I'd like to start by introducing the guest speakers who have kindly agreed to join us today. Brenda Wong is Professor of Clinical Pediatrics and Neurology based in Cincinnati, and she will be speaking about the redosing program in North America and about the natural history study. Thomas Voit is Professor of Pediatrics based in Paris, and he will be speaking about the recent Phase 2 study publication and also say something about the use of MRI. Annemieke Aartsma-Rus is Associate Professor at the Department of Human Genetics at the Leiden University Medical Center, and she'll be giving a talk about biomarkers and dystrophin. The first thing I'd like to do is just to say something about the recent events which have been made public through the press releases. The first one to mention is in June, the $200,000 research grant from Parent Project Muscular Dystrophy, which is intended to fund the multi-exon skipping program. In August, the Cure Duchenne agreed to provide up to €5 million to advance the DMD pipeline, and this will be used primarily to help progress the PRO-044 program, but also to support the redosing and to support the 045 and 53 programs. And I'd just like at this point just to say how grateful the company is for the support from the patient organizations. The publication in Lancet Neurology, of course, Thomas will be talking about later. Then I'd like to mention that we have 12 presentations at the World Muscle Society in Berlin, and perhaps I'll get an opportunity to meet some of you there. The commencement of the redosing of Drisapersen in North America is obviously a very important topic from 17th of September. Brenda Wong will discuss that later. Then we also have had a very interesting publication in PLOS ONE, on the 24th of September, which describes a semi-automated image analysis method. And finally, the 25th of September, the start of the redosing program in Europe, and I will come on and discuss that one just now. I'd also just like to mention at this point that there is information on the redosing program on our website in the patients and family section if anybody wants to look further into that.
Hello.
So, Prosensa is working to provide access to all previously treated patients where possible, and the primary aim of this is redosing. It's really not data collection. So there'll be no biopsies in the redosing program and minimal procedures really to try to minimize the burden. I wanted just to differentiate between boys who are have been in a clinical trial that is still open and boys who've been in a clinical trial that's closed, because the procedures are a little bit different and it does affect some of the timelines. So the clinical trial is still open. Probably some of you are familiar with the numbers. The DMD114673 extension study, which took place in Belgium and Sweden, and the DMD115501 study, which took place in North America. And both of these studies are officially still open, so redosing can actually be implemented using protocol amendments. For the clinical trials which have been closed, the aim is still to provide continued treatment for boys who would like to continue. But here we have to go via individual country-specific procedures. And I'll say a bit more about that in just a moment. So first of all, to talk about the redosing program in Europe. Just to recap, the study, which is known by two different names actually, PRO 5102 and DMD114673. So this was a phase 1-2 open label study, escalating dose, to look at the effects, safety, tolerability, and pharmacokinetics of multiple subcutaneous doses of Drisapersen in patients with Duchenne muscular dystrophy. The dose escalation part actually took place in 2008 to 2009, and 12 boys participated in that between the ages of 5 to 16 when they entered the study, and these were both ambulant and non-ambulant boys on steroids. The extension part started in July 2009, and all 12 boys actually continued into the extension phase. But the dosing was halted by GSK on the 20th of September last year. The patients have actually been followed every 12 weeks on an optional basis. And the study is still open, which is really important for the redosing part of the program. So for the resumption of dosing, all 12 boys have been invited to continue in the study with the resumption of dosing. And I just wanted to emphasize that this is for both ambulant and non-ambulant boys who are eligible to participate. So the first patient recommenced dosing in Leiden in Belgium on the 25th of September this year, and we're expecting the other boys will follow over the forthcoming weeks. We're still waiting for regulatory approval in Sweden. It's been a little bit slower than in Belgium, but we are expecting that approval soon. So now coming to the redosing outside of the clinical trials. This is for studies that are closed. And I would say that Prosensa is working currently on all countries simultaneously. We are looking at all the countries together. But each country has its own regulations and timelines to start these kind of programs, and it's different in each one of these. It's possible that it may not be feasible in some countries according to local laws and regulations, but we do think that this will be possible in the majority of cases. We're also working with a company who has significant experience in this kind of program, and that will help to speed up the process and ensure that it goes as smoothly as possible. So the country rollout plans are being developed at the moment, and we are in contact with the doctors who will be involved. So you can keep in regular contact with your doctor and he will be able to inform you about the rollout in your country. We also want to pursue home dosing in as many countries as possible. And again, this does depend on local regulations and requirements, and sometimes also the site requirements. It's not the same everywhere. But where possible, we would like to do that. And again, this hopefully will ease the burden of participation. So the first country is planned to be active by the end of this year, and we hope to be able to start others soon afterwards. And we will communicate that, of course, as soon as that's possible. How long can the program run for? Well, as mentioned, the program aims to bridge the gap between the end of the clinical trials and the commercial access. So the boys can actually continue in the study until certain things apply. So, for example, of course, if they elect not to continue, everybody would be free to stop with this program at any time for any reason. Or if Drisapersen is granted regulatory approval and then becomes commercially available, because then those programs are no longer valid and so would not be allowed to continue in that country. Or if the company or the regulatory authorities needed to terminate the program for reasons such as safety issues or ethical issues, for example. I'll now just give you a brief regulatory update. Many of you will know about the FDA guidance letter that was received by Prosensa on the 2nd of June, following the meeting on the 14th of May. And this letter outlined a clear regulatory pathway for Drisapersen under an accelerated approval process. So we will pursue an NDA, a new drug application filing for Drisapersen, with the FDA under the accelerated approval pathway. And this will be based on existing data, and we'll do this before the end of this year. We plan to initiate 2 confirmatory studies, which will need to be commenced prior to the anticipated approval. We're also interacting closely with the EMA, and we plan to file for a conditional approval shortly after submission to the FDA. And just to mention, the conditional approval in Europe is rather similar to the accelerated approval process in the US. There are some slight differences, but they are broadly similar, based on the concept that additional data needs to be provided later on. I'd like now just to mention also about the confirmatory studies that have been outlined in the FDA guidance. So we're having ongoing discussions with the regulatory agencies about these, and these studies will then support the accelerated approval or the conditional approval for Drisapersen, and are anticipated to begin in the first half of next year, prior to the approval. The first one to mention is an open label study of Drisapersen with a historical control. So Prosensa's fully enrolled natural history study, which we will talk about later, with 269 patients, may serve as control for this study. And I wanted also to mention at this point how grateful we are for all the boys taking part in this natural history study. It's very important. Secondly, there's a randomized placebo-controlled trial of another exon-skipping drug with a similar mechanism of action, directed at a different exon, and the PRO 044 may serve this purpose. So I will say a few words about the confirmatory study. The objectives of the confirmatory study are to investigate the efficacy of Drisapersen versus the natural history control, as I mentioned, in patients with Duchenne muscular dystrophy. And it's a confirmatory study to confirm the positive benefit-risk ratio of Drisapersen. And as I mentioned, this is needed under the accelerated approval pathway. Important to mention that no biopsies will be taken in this study. So again, less burden than perhaps some of the earlier studies with biopsies. And again, just to emphasize how grateful we are to the boys for taking part in the study. It's really important for many reasons, also because the The imaging and the biomarker data that will come out of the natural history study will provide important data for evaluating disease progression, and that perhaps can be used in many different programs, not just in this one. So it really has far-reaching value. To say a few words about the other programs, as you realize, obviously, the company has been very much focused on Drisapersen and is still very much focused on Drisapersen because of the filings. But the other programs are also still extremely important, and the company is fully committed to moving those forward as fast as possible. The PRO-044 study, as was reported by Giles in the previous webinar update, the modeling predicted an effective dose range in the 6 to 9 milligrams per kilogram IV. And the current status of the extension study is now that that's in the startup phase. So the first boys are expected to start in that study in the fourth quarter of this year, so rather soon, in line with what was previously promised. The phase 3 placebo-controlled study is currently in planning, and that's expected to start in the first half of 2015 in the US, Europe, and potentially other countries as well. So there'll be more information on that and updates as soon as that's feasible to do. For the other DMD compounds, the PRO-045, the dose-finding study is still ongoing. We now have 5 cohorts completed in that, so that's 15 patients completed, 3 in each of the cohorts. We expect some results from that in the fourth quarter of this year. So then there'll be an expanded treatment phase, which is planned to begin in 2015, again in the US, Europe, and potentially other countries as well. Similarly, for the PRO-053, the dose-finding study is still ongoing. We have 3 cohorts completed in that study, so that's 9 patients, 3 patients in each cohort. And the results are expected in the beginning of next year, the first quarter of 2015. And the expanded treatment phase for that study is expected also to begin in 2015 in the US, Europe, and potentially other countries. For the 52, and for the prospect, these are still in preclinical, and their preclinical studies are ongoing. Obviously, this is a very exciting program for the company because this would allow treatment potentially for many rare mutations using the single product. But it takes time, and the preclinical work is moving forward, but it still takes some time. So the clinic is still a little way away. So now I'd like to hand over to Brenda Wong.
Thank you, Tony. Hello, everyone. This is Brenda Wong from Cincinnati Children's. I'm really pleased to be able to provide the update for the Drisapersen redosing program in North America, and also to talk about the natural history study update. For the next slide, we have this redosing program in North America, as mentioned by Tony, really has been with regards to the patients or subjects that had been in the open clinical trial in the 501 study in the U.S. And at the time that the dosing was held, 3 sites were in the 501 study. And but in addition to these 3 sites, this study that is for redosing has also been expanded to include additional 8 sites from the US 876 study. At the same time, there are 3 Canadian sites from the 349 study, which is the extension of the phase 3 study of the 044 study, are also participating in this redosing program. So we have a total of 14 sites in North America, and we expect up to 72 patients or subjects to participate in this redosing phase. It is good that we have the use of Green Fire to assist with patient travel arrangements, and the fact that to alleviate the burden of this, we have the availability of working with medical research network, that's the home health services, to provide home dosing options as well. So we have here an update of the first patient being dosed here at Cincinnati on the 16th of September 2014. Of date, 5 patients have enrolled and 4 patients have been redosed as of yesterday. 2 of the 14 sites in the U.S. have obtained IRB approval, and contract negotiations are ongoing with the remaining sites. Over in Canada, submission to Health Canada is in preparation, and the Canadian sites will be submitting to the IRB in parallel to that process. We expect the first Canadian site to be initiated in mid-November next month. So each site setup is really dependent on the regulatory processes for IRB approval and site contracts. We'll quickly summarize the updates for the natural history study. This is a study that is a prospective study of the progression of physical impairment, activity limitation, and quality of life in Duchenne muscular dystrophy. The aim is to address the needs of investigators and patients for a better understanding of Duchenne muscular dystrophy. Although there is no study drug administered in this study, it is a very important study, as Tony has mentioned. This is because as time evolves, we have seen the change in the natural history of Duchenne's, and at the same time, we are all very aware of the variability in the rates of progression of Duchenne patients. So the data that we obtained from this study that will determine if the rates of decline are influenced by other confounding variables besides mutation, steroid use, and other care issues, we would be able to understand better with the natural history study data to really design clinical trials that is upcoming with this program for exon skipping. The natural history study also captures biomarkers of safety and disease progression, and that will enable us to also identify the subpopulation's outcome measures as well, so that all in all, we will be able to provide comparative data for Duchenne patients with rare exon deletions and mutations for which formal controlled trials are not feasible. So as what Tony has mentioned, the natural history data will provide the background for the other exon skipping programs whereby we have limited patient numbers for placebo-controlled trials. The next slide. Can we move the next slide, please, for me? I think my slides are being stalled.
Hold on 1 second, Brenda.
Yeah. While waiting, the next slide actually, if you guys have it, it's really the map of the sites for the natural history study. It is an almost international study that involves sites in Europe, in U.S., and South America.
Brenda, sorry to interrupt you, Brenda. We actually are not able to advance these slides either, so I think we should just wait for a couple of moments and see if the technical problem can be solved.
Oh, okay. So it affects everybody else as well?
Yes.
Yes.
Okay. Great. It's back for me. Good. So this is a slide that shows that the map that shows that it is an international study that involves sites in North America, in Europe, as well as South America. An update for this study, we are pleased to say that this study has completed enrollment and has enrolled 269 boys with confirmed Duchenne muscular dystrophy between the ages of 3 and 18. So 10 countries are involved across 16 centers in America and Europe, as you have seen on the map. The study involves both ambulatory and non-ambulatory boys. It is a 3-year study with each clinic visits that the patients come to clinic with clinical evaluations, PT evaluations, and annual draws for biomarker studies where we obtain blood and urine every 6 months, every year, but the evals are every 6 months. And so here we do involve the boys on physical testing as well as obtaining the quality of life measures as Duchenne's evolves over the 3 years of follow-up. So you can see that this is a really ambitious study that really will enable the community to obtain natural history data that will help improve the understanding of Duchenne's, and this provides really the background for investigators to design studies in the coming programs that we have, and at the same time for clinicians to really understand the clinical cause to enable clinical interventions as well. So this really is thanks to all the families that have enrolled in this study and have committed their time to their visits every 6 months to enable the natural history data to be collected, which is just as important as any clinical trial. So thank you, everybody, for your attention, and I'll pass this over to our next speaker, who is Dr. Thomas Voit from Paris.
Thank you very much, Brenda. Hello, everybody. This is Thomas Voit from the Institute of Myology in Paris, and I want to go with you across the data that has been recently published on the DEMAND-2 study. Can you just move on one, please? Here it comes. So this was a phase 2 study on the safety and efficacy of Drisapersen for the treatment of Duchenne muscular dystrophy. It was, as a study, constructed to respond to the question of either continuous dosing or intermittent dosing of Drisapersen 6 milligram per kilogram or placebo. So there were altogether randomizations in a way that in every arm, so either continuous treatment or intermittent treatment, 2 patients were treated and 1 patient was a placebo control. So the randomization was 2 to 2 to 1 to 1. The primary endpoint was the change in the 6-minute walk distance at week 25, but the whole treatment phase was for 1 year. So the primary outcome was at the half-year point. That's very important, but the patients were followed through in the study through the whole year. And safety assessments, of course, included renal, hepatic, and hematological monitoring and other adverse effects. This was, of course, a double-blind and placebo-controlled study. It concerned Duchenne boys older than 5 years and, very importantly, able to rise from the floor in less than 7 seconds. We know today that this is a very important criterion for the interpretation of this study, because these were Duchenne boys who were ambulant and able to perform still very well. So this shows you how the study was designed. There were initially 53 patients randomly assigned, of which 18 were allocated to placebo and included in the intention to treat group, and 17 included in the per protocol analysis. one of the patients did not meet the inclusion criteria for genetic reasons or a different reason. 18 patients were allocated to the continuous treatment arm with 6 mg per kg, and 17 were allocated to the intermittent treatment arm, of which 15 were then included in the per protocol analysis. So, what was the major outcome? Please remember that the primary endpoint was set at week 25. So at week 25, the 18 boys in the placebo group, and 16 were calculated for this, had lost 3.6 meters on the 6-minute walk test, whereas those on continuous treatment, again 16 in this analysis, had gained 31.5 meters, and 15 in the intermittent dosing had remained stable. If you look at the same data at the end of week 49, so after the year of treatment, those in the placebo group had continued to lose 24 meters. Those in the continuous treatment group had continued to be above the baseline and were 11 meters better than when they started. And those who were in the intermittent treatment group had also gained 2.5 meters above what was their initial value. So there was a clear difference, which was actually statistically significant, although the study was not powered to be really statistically significant, for the primary endpoint between the continuous dosing group and the placebo group, whereas the difference was not fully statistically significant at 49 weeks. If you look at that in the graphic, it shows the same thing you've just heard from the numbers. So the continuous treatment group, after starting the treatment, improved and then maintained the improvement, lost slightly, but at the end of the treatment of 49 weeks was still clearly above the 6-minute walk distance, which they were at the beginning of the treatment. The intermittent treatment group also gained a bit and then more or less maintained the baseline and was just 2 meters above the baseline at the end of the treatment group, but the treatment period, but did not lose on the 6-minute walk test distance. And the placebo group, from the beginning, continuously lost, and almost with the same speed, a bit more accelerated towards the end, and basically lost 24 meters. So, the muscle biopsy results, because there were muscle biopsies taken, showed that the exon 51 skipping was detected for almost all patients in more than 85% if one takes all the methodologies applied. There was an increase in expression of the PCR product on exon skipping, and that was tested in the biopsy at week 25 in 2 patients in the continuous treatment group and 5 patients in the intermittent group. For all those who think, why was it not detected in every patient, mind you, as in these studies, it is only possible to take a very small bit of muscle. Finally, this small bit of muscle has to be judged as being representative of the whole body, of the 10, 15, 20 kilograms of muscle the whole body holds, and you're just dealing with maybe half a gram of muscle that gets analyzed. So that is very important to take into consideration. If the increase in dystrophin intensity was assessed under the microscope by immunofluorescence, also the increase in fibrodystrophin was clearly more in the Drisapersen treatment groups, both continuous and intermittent, and Western blot showed that patients only in the active treatment groups had an increase from baseline at week 25. So most patients, if we look at the adverse events, most patients reported mild to moderate on-treatment adverse events. No adverse events led to withdrawal, so all patients could complete the study. The most common adverse events were injection site reactions and renal events, usually subclinical proteinuria, that receded if there was a treatment pause. And that was seen in 8 patients in the continuous group and in 11 patients in the intermittent group. None of the adverse events relating to injection sites were reported as severe or serious. So taken together, there was an acceptable adverse event profile, and there was clearly a statistically positive result of the treatment for the continuous treatment group, for the primary endpoint, and there was also positive result, but not quite statistically significant, for the intermittent treatment group. The intermittent treatment group, if you want, took a bit longer to show the effect that was seen earlier in the continuous treatment group. Now, I want to just briefly touch on the use of MRI. I already touched on the use of muscle biopsy. Of course, we are being asked, do you have any evidence in terms of biomarkers that the treatment you're applying beyond 6-minute walk test or other functional tests really improves the tissue, and is this due to dystrophin increase? And of course, the limitation of a muscle biopsy is that you're looking at a very, very small bit of muscle. And certainly patients are happy if we're not even taking a small bit of muscle. So it is obvious that imaging, if it was sensitive enough to really observe an effect with such a treatment, would be very useful, because we could study more muscles, more muscle groups, different muscle groups, and we would not have to hurt the patients, or we would not have an invasive procedure. So what can magnetic resonance imaging detect? All patients know these scanners that are in all hospitals nowadays, and the MRI of skeletal muscle can detect changes in muscle structure, and also can detect fat in the muscle and surrounding the muscle, and can detect fibrosis, so scar formation, again, around the muscle and in the muscle. And in Duchenne muscular dystrophy, as we all know, over time, the replacement by fat and fibrosis is one very important thing that handicaps the muscle, because there are less muscle fibers in the long term. MRI can also detect muscle inflammation, and due to these characteristics can be used as a prognostic parameter, but can also be used to monitor treatment effects. In animals, this has been shown, but here it is shown for the first time, also in patients treated with Drisapersen 6 mg per kilogram, and this is data that comes from the American study, the DEMAND-5 study, and what you can see on these graphs is that overall in patients who were treated with 6 mg per kg, after 24 weeks in blue or after 48 weeks in red, there is less apparent fat if you measure the fat fraction in the muscle on MRI, and on each graph there's a percentage. There's less fat in different muscles, like in the rectus femoris, or in the vastus lateralis, or vastus intermedius, or vastus medius, or in the biceps femoris. So, and of course the effect is not exactly the same in the different muscles, but all muscles do show some effect. That is very encouraging, because it's, to my knowledge, the first time that there is objective controlled data showing that muscle MRI can be useful to monitor the treatment effect of this drug in the human. With this, I pass on to Annemieke. Annemieke?
Oh, thank you. We were unmuting the telephone. Thank you, Thomas. So I'm Annemieke Aartsma-Rus, and I will talk today about biomarkers and dystrophin analysis. So I will first give a brief introduction on biomarkers, what they are and how they can be used, and then I will talk in some more detail about dystrophin analysis in clinical trial samples. So what is a biomarker? Well, the official definition of a biomarker is that it is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to a therapeutic intervention. And what that actually means becomes more clear when we look at different types of biomarkers and how they can be used. So, for instance, there are diagnostic biomarkers that are markers or indicators that something is wrong. There's also prognostic biomarkers that when you know you have a certain disease, having low levels or high levels of a certain marker can predict whether the disease course will be mild or severe. And there's also markers that can allow therapeutic monitoring, and these markers predict whether a therapy will work or show that the therapy is working. And it's good to bear in mind that sometimes one biomarker can fit all categories, but usually a biomarker is either diagnostics or prognostic or a marker for therapeutic monitoring. So there is a biomarker already used for Duchenne muscular dystrophy, and that is the serum creatine kinase, also known as CK. So CK is an enzyme that is very abundant in muscle tissue. So what happens if there's muscle damage? The CK will leak into the bloodstream, and you can measure that there is elevated levels of CK in the bloodstream. So in Duchenne, because it's a muscle wasting disease, in young patients, CK is elevated. However, this is not a disease-specific biomarker because it's an indication of muscle damage. There's other diseases that also cause muscle damage, and even people who do strenuous exercise, there will be elevated CK. However, when patients present with muscle weakness, elevated serum CK indicates to clinicians that probably the cause of the disease is a muscle disease. However, you cannot diagnose Duchenne based on CK. You also need genetic analysis to confirm the DMD mutation. There's also therapeutic biomarkers, and for this there is no therapeutic biomarker yet available for Duchenne, but there's different types. So there are therapeutic monitoring biomarkers. You can use these, for instance, to identify responders. And this is often used in cancer treatment. For instance, before the trial, you can screen patients to know whether they are likely to respond to chemotherapy, and then you only give the chemotherapy with all its side effects to the patients where you know that they will like to respond, and not to the patients where you know they will not respond. You can also do this during the trial. You can also do this during the trial to identify those patients who are responding and then continue only with the responders. There's also pharmacodynamic biomarkers and surrogate endpoints. And what a pharmacodynamic biomarker is, it's a marker to assess whether the treatment works as proposed. So it's a confirmation of the drug mechanism. So for instance, a pharmacodynamic biomarker for exon skipping studies or studies for ataluren could be dystrophin restoration, because the aim of these therapeutic approaches is to restore dystrophin. However, if a therapy aims at antioxidation and reduce of fibrosis, then you could analyze a muscle biopsy for fibrosis, or you could look with the MRI that Thomas Voit just introduced to see whether indeed you see reduced fibrosis. It's good to bear in mind that the pharmacodynamic biomarker is not the same as a surrogate endpoint, because the regulators, the EMA and the FDA, have certain criteria for surrogate endpoints. And that is that a surrogate endpoint needs to have a strong correlation with the clinical endpoint, as has been convincingly demonstrated by appropriate data. This is the EMA definition, or is reasonably likely, the FDA definition. So what is a surrogate endpoint? A surrogate endpoint is something that you use instead of an outcome measure that measures clinical benefit. So normally drugs are approved by the regulators based on whether or not they see clinical benefit. If you can find another biomarker that correlates with clinical benefit now or in the future, you can use this instead of your functional outcome measure. So it's a tool that can be used to accelerate the process of drug development. The advantage of using surrogate endpoints is that sometimes they may be quicker. So, for instance, with the 6-minute walk test, maybe you need to test for 1 year or even for 2 years. And if we can find a surrogate endpoint, a marker in blood or in muscle that already shows improvement after 3 or 6 months, that would be an advantage. Another advantage is that these are markers that you measure in body fluids or in muscle, so they don't rely on motivation, and they probably will also vary less than functional tests. It's good to remember, at the moment, there is no surrogate endpoint available yet for Duchenne. So I will now talk about the dystrophin analysis. So dystrophin can be used as a pharmacodynamic biomarker for exon skipping studies because dystrophin, the aim of the exon skipping is to restore dystrophin. So some history about dystrophin analysis. So about 20 years ago, the idea was that patients who had less than 3% dystrophin had Duchenne, and patients who had more than 20% of dystrophin had Becker. And everyone who had dystrophin levels in between was classified as intermediate. So this was done with the state of the art at that time, but at the moment, the techniques have developed a lot. So they are much more sophisticated and sensitive and reliable. So there has been some new insights based on this. So first what we know is that there's also Becker patients who have much less than 20% of dystrophin. So there's Becker patients who have 8 or 9% of dystrophin. It's also now known that most Duchenne patients make some dystrophin. So this less than 3% doesn't mean zero. Most Duchenne patients make some low levels of dystrophin. And here we can distinguish between the revertant fibers, which are a few fibers that express dystrophin at very high levels, and trace dystrophin, and most Duchenne patients will have very low levels of dystrophin in most of the fibers. And you can see the difference here in this slide. So you see 3 fibers that have very strong green staining for dystrophin, while all the other fibers, so this is an untreated Duchenne patient, all the other fibers you can see there is some weak green staining. So these muscle fibers make some dystrophin. So these are the trace amounts I was talking about. So what we also know is that even very low levels of dystrophin can already lead to a better function. So we know this from Duchenne patients who need exon 44 skipping. So these patients do have Duchenne, I want to stress that. But when you look at the functional decline with the 6-minute walk test, they show a slower decline than patients who need skipping of other exons or patients who would not be eligible for exon skipping. Another study has looked at the age at loss of ambulation, and then again you see that patients who need exon 44 skipping have a higher age at which they become non-ambulant. And a very recent publication that just came out yesterday from Francesco Montoni has actually looked into patients that need exon 44 skipping, and their dystrophin levels are higher than those of other patients. So they're still very, very low, but they're higher than other patients. So this really underlines that very low levels of dystrophin already improve function. However, all these patients are born with very low levels of dystrophin. Of course, with exon skipping, what you want to do is restore dystrophin at a certain point in time. So quantifying dystrophin, when you want to measure it, in general it's difficult, but in clinical trials it's very challenging. These challenges arise because dystrophin is a large protein, it's very low abundant, and in most Duchenne and Becker patients the muscle quality is quite poor, and this hampers the analysis. There's different ways to quantify dystrophin, and in clinical trials so far what has been used are immunofluorescent analysis and Western blotting. And today I will only go into the immunofluorescent analysis because this is the most sensitive method. Well, because most patients have these trace amounts of dystrophin, when analyzing patients you need pre- and post-treatment samples because not all patients have the same levels of trace amount. So you really need to know what a patient has before treatment and compare it after treatment. So how does immunofluorescent analysis work? What is used is muscle cross-section. So a biopsy is taken and cross-sections are made. Then a fluorescently labeled antibody is used which recognizes dystrophin. So that way, fluorescence means that there is dystrophin. This is an extremely sensitive method, and it measures how many fibers make how much dystrophin, because if there's more dystrophin, there will be more fluorescence, so the fiber will be more brightly stained. So you know also where the dystrophin is located, whether it's located properly at the membrane or somewhere else. What you do not know is the size of the dystrophin. This you can do with Western blotting, but you cannot do this with immunofluorescent analysis. So what do you need to know when you analyze clinical trial samples? Well, you need to know how many fibers are dystrophin positive. And, of course, then you also need to apply a threshold. When do you call a fiber dystrophin positive? And this threshold, of course, you have to apply to all the samples in the same manner. And also what you want to know is how much dystrophin is made in each of the different fibers. So there's different methods that have been reported for this, and Tony already mentioned the one that was published last month by Prosensa, and this is, I think, so far the most sophisticated method that really allows to look at the dystrophin levels of each individual fiber. So I will not go into the whole methodology, but I will just point out that it's a very complicated process. It takes many steps, and also it doesn't analyze just a few fibers. Generally, for each sample, 1,500 fibers are analyzed. So this is really a lot of work, and it has to be in a very standardized way, taking along controls, etc. So then what you get with this methodology is shown in this picture. So on the left you see spectrin staining, and right spectrin is a muscle marker. So all the fibers that are stained red are muscle fibers. The system that Prosensa developed can then analyze or identify each of the fibers, and you can see all the numbers where all the different fibers are identified. And then in green on right you see the dystrophin staining, and this is a healthy muscle. And what you can see on the graph, which shows how what the intensity is of each of these individual fibers, not all fibers have the same amount of dystrophin, even in a healthy person. And when you compare different persons with each other, and when you compare within one person different muscles with each other, there is variation. So within one individual, the dystrophin levels in different muscles will differ, and between individuals, the levels of dystrophin of the same muscle will also differ. So this makes using healthy muscle as a control, or saying there is 5% compared to wild type, or a healthy muscle, makes it difficult, because what 5% is will vary between different healthy individuals. So this is a comparison of two Duchenne samples, DMD1 and DMD2, a Becker sample, and a control. And what you can see for the control and the Becker patients is clear dystrophin, and you can see that it's less intense in the Becker patient. And what you can see for DMD2 is there's no dystrophin visible, and for DMD1 you can see two revertant fibers. However, when you use a more intense laser, so you look into this with more intensity, you can see the dystrophin trace amount in DMD1 and DMD2. You just cannot see it now because you compare it to the control, which had much more dystrophin. So this is again the picture that I showed before with the revertant fibers and the trace amounts of dystrophin. And what you can see with the Prosensa methods, you can really distinguish this. So on the left, you see a very high peak. So this is a lot of the muscle fibers having very low amounts of dystrophin, but more than nothing. And then the revertant fibers, you see very few small peaks. These are 2 or 3 or 4 muscle fibers having very high levels of dystrophin. And with this methodology, you can distinguish these two types of fibers. So then dystrophin analysis was done on the study that was just discussed by Thomas Voit. And you can see here the analysis that was using the Prosensa analysis that was published. You can see for all the samples, we have placebo, we have the 2 treatment regimens, and we have samples before treatment, so that is week 1, and we have after 24 weeks of treatment, so that is week 25. And what you can see is that there is dystrophin, these trace amounts, for all samples. However, when you quantify it with this system, what you see for the placebo is that the lines in yellow before treatment, 25 weeks after treatment, the green line, they are more or less overlapping, meaning that the dystrophin levels before and after treatment are very similar. What you see for the 2 treated samples is that the green line is shifted to the right. And what this means is that there are more muscle fibers making more dystrophin. So there is a shift there. This is indicative of an increase in dystrophin levels. So in summary, the analysis of dystrophin is very challenging, and you need very sophisticated technology for clinical trial assessment of dystrophin levels, and especially because these are large numbers of samples, the fact that this method is semi-automated is really crucial. For drug approval, of course, having a functional effect is most important, and Thomas Voit explained about the 6-minute walk test where the treated boys appeared to do better. However, information on dystrophin restoration before or after treatment can be helpful additional information because the drug mechanism of exon skipping is dystrophin restoration. For a surrogate endpoint, what we would need is a correlation between dystrophin levels and the 6-minute walk test levels, and so far in exon skipping trial, this relation has not yet been found. And thank you, and I hand over to Tony.
Thank you very much, Annemieke, and I would just like to take this opportunity to say thank you to all our guest speakers today. Thanks to Brenda Wong, to Thomas Voit, and to Annemieke Aartsma-Rus for your participation. I'd also like to take the opportunity to say thanks very much to all the boys who've participated or are participating in the Prosensa clinical programs. Of course, we know that it takes a great amount of commitment, a great amount of time as well to take part in these clinical programs, and recognize, of course, that the last months have not been easy. So it's also important to say that we really do remain committed to doing what's in the best interest of the Duchenne community. And I've been with this company a very short amount of time, and one of the things that struck me is the level of commitment from the people in the company to do what's really best for the Duchenne community. So with that, what I'd like to do is to hand over to Elizabeth for the question and answer session.
Hello, this is Elizabeth again. Through our member organizations worldwide, United Parent Project received questions for this webinar. However, some questions may already be answered during the webinar, but as repetition is not harmful, we will nevertheless ask these questions, and you might hear answers you might have heard before. But the first question, I think I would like to address that to Dr. Wong, is a question we often see. Will patients who previously participated to the Drisapersen study and lost their walking ability during the last year be eligible to participate to the redosing program?
Thanks.
Can you answer that question? Yeah.
Thanks, Elizabeth. Yes, all patients or subjects in the trials of Drisapersen that we have mentioned in the redosing program, in the previous open trials, in the trials that we've stated, even if they have lost ambulation, they will be eligible to continue with the redosing program.
Thank you so much. That will be a relief for a lot of people, believe me. Yeah. And then the second question is, after Belgium, will the study start again in Italy as well? In the case so, will all the centers who previously participated in the study be involved? And maybe I can address that to Anthony Hall.
So the answer to this really is coming back to the slides that I presented on the different types of redosing, so for the studies which are open and the studies that are closed. So for the Belgian sites that were in the 673 study, that site is still open, so for those boys can go through the quicker and actually slightly easier starting up process. There's also Belgian sites that was in the latest study, the phase 3 study, which has now closed, and that's then the same for Italy. So in those cases, we need to start these up through the local procedures that I mentioned. So the short answer is yes, we will expect to be able to start also in those countries, but it has to go through a different process. It's not a matter of restarting the study.
Okay, thank you. And then the next question was, in countries other than North America, are there any reasons other than logistical issues preventing to start redosing in those countries as well?
No, really the issues are logistical. Each country has its own regulations about these kind of programs. And so in some countries it's relatively straightforward, in others it's more difficult, and in a couple that we're aware of it's actually not possible. So it's really the logistics that comes into this and determines it.
And then in the last press release, September 26, it has been said that Prosensa is urgently progressing preparations to roll out similar programs of redosing in other European countries and globally for all previously treated Drisapersen patients via expanded access, compassionate use, or named patient programs where feasible. Does this mean that all previously treated patients from other countries will be redosed only through expanded access, compassionate use, or named patient programs? Or is the company working in parallel to these options to allow Drisapersen availability to all patients that could benefit apart from the trial?
So the answer to this question overlaps a bit with what I've said before. There are the two mechanisms. So we are doing these in parallel, but for the open studies this goes faster, and then for the other programs, the local programs, that takes a little bit longer and is country specific.
Right. And then I think the other question you also answered more or less, but maybe I still ask it, is will home dosing be an option in all countries where the program will commence again?
Yes, we hope so. But in some countries the legislation doesn't allow it, and it may be that in other countries the site won't allow it. So we can't say 100% at the moment that it will be allowed or possible in each country, but at least that's what we would like to try to do.
Right. Is Prosensa considering bringing Pro 44, Pro 45, Pro 53 to Spain?
So I can't really comment on a specific country at this point, but what I can say is that Europe will be included in these programs, and so obviously for the specific countries we will release more information on that when the time comes.
Okay. And then if expanded access, compassionate use, or named patient programs are methods to redose, as mentioned in this press release, what do those terms mean?
Actually, they're really pretty much the same thing. They're just local terminology for for expanded access kind of programs. In some countries they call it compassionate use, in others they call it named patient programs, but effectively they're the same thing.
Okay, and then we already come to the last two questions. One is, what is the outlook for 10 to 30 multi-exon skipping, and when is it expected to reach clinic?
So I think I had one slide on this.
Yeah.
It's still in pretty early stage, in preclinical. So the clinic is actually aware, and I think at this point it's not really feasible to comment on an exact timeline for that.
Right, thank you. And then somebody brought up a question on the recent press release on the methodology for dystrophin analysis, and they just wanted to know if you would touch on the usage of this method in the future. That was the question. Like, will you always use this method in the future?
Yeah. So I think so. This of course depends on whether muscle biopsies are part of the clinical trial. So, like I explained, the dystrophin restoration is not crucial for drug approval. You need to show clinical benefit. If there is a biopsy taken, then of course having information on whether dystrophin is restored or increased is extremely useful additional information. And with the method that Prosensa has now set up, this can be analyzed in very much detail. But if there is no biopsy taken in the trial, then of course you cannot assess dystrophin levels.
Thank you. And then on behalf of all families united as members of this umbrella organization, I would like to thank everybody who helped to make this webinar happen. That's Prosensa, the guest speakers, and Parent Project MD for their technical support, and last but not least for Daniela to start again when the slides were stuck. Thank you so much, and there's one thing to say to all of you, which is that this presentation, this webinar will be up on the website of patient info at prosensa.nl, right? And we will update you so you can link from your individual websites to this webinar for people who missed it or want to see it again. Thank you so much again.